Sure.
Hi, George. Hi, Mick. Welcome to our podcast. With us today in our first episode are Dr. George Rogu from Long Island and Dr. Mitch Connors. Mitch, would you like to tell us how you got to be a pediatrician?
Yeah, Herb, call me Mick.
Yes, Mick. I always call you Mitch.
That's right. I've been called worse. You want to try it again?
Yeah, we can try it again. So, welcome to our first podcast.
Hold on. I gotta leave. Oh,
No, don't leave. I'll edit it out.
all
Yeah,
right.
you can splice the dice if we're going to do it that way.
Is it
Yeah.
still recording? Okay.
Yeah, it's recording. All right. Welcome to our first podcast. With me is my co-host, Dr. Mick Connors and Dr. George Rogu. Would you like to tell us how you got to be a pediatrician, Mick?
Yeah, my story is pretty easy. My brother passed away before I was born of Wilms tumor, and I grew up with my mom's stories about the care that he received, and that just really inspired me. It's been a passion that I haven't been able to shake to try to get better care for kids throughout my lifetime.
Wow, that's a very compelling story. And you, George?
I always wanted to be a doctor. I grew up in high school in the 80s. My family wasn't wealthy. I was Romanian, so they sent me off to communist Romania to medical school because I spoke the language. Went to medical school there during the Iron Curtain, saw the Berlin Fall while I was there, very interesting. And came back to the United States, passed the USMLE, and then did residency in pediatrics at Montefiore Medical Center. And then went into private practice, and then that's it.
How was it different practicing medicine in a socialist/communist system than the American system?
Well, when we came to the United States, it was totally a different thing. Fortunately, back then it was just paper. Could you imagine if you did that and it was electronic health records like it is today? We were students, so it was not that complicated. You went to a lecture, you had a professor, but you had that hierarchy of physician or professor to student, which was very, very profound. And I think that lasted for the next 30 years. I think it's finally going away.
And how about the clinical, where you're more hands-on clinical than labs and CTs and MRIs than in American medicine?
Oh yeah, back then there was basically everything was clinical, and they didn't have CTs, they had X-rays. CTs were like a brand new super duper thing. I visited a lot of the orphanages. Saw the children, how they lived in orphanages, hence how I developed that adoptiondoctors.com consulting, reviewing medical records, because I saw them how they live firsthand and how the social or the lack of the maternal child emotional connection made the children have developmental delays and everything. So I understood what these kids went through by seeing it firsthand.
And Mick, you were at Cincinnati Children's Hospital, right? That's one of the premier institutions in the country.
Yeah, I did my pediatric residency at Cincinnati Children's, and then my wife got a job at IBM in White Plains, New York. So I did my first year of fellowship at Jacoby Medical Center and actually crossed paths with George. We've realized at some point in those early 90s, and then finished my fellowship training back at Cincinnati when we decided to get out of New York.
Oh, wow. And how did you end up in Nashville?
Nashville really came about in the last few years when I started a tech company called Anytime Pediatrics. So we moved over here for the resources and technology and investment and just kind of the community. So that's how we wound up in Nashville. But when I left training in Cincinnati, I actually moved to Knoxville, Tennessee, really because I wanted to be more clinical and hands-on. So I went to a small freestanding children's hospital where I could just take care of patients and not worry about research and administration and all those kind of things. So it was a completely clinical job, which was rare in a hospital that's non-academic, children's hospital. That was unique, and it was really a phenomenal experience.
So I lived in Abingdon, Virginia, which is not too far from Knoxville. Knoxville is the next biggest city. So for those who are not familiar with Virginia, Virginia is exceedingly large. And that corner is very rural and not a lot of access to care. So the next big city is in Tennessee called Johnson City, and then it's Knoxville. So it's a very pretty area of the country. George, why did we want to do this podcast? What is our mission?
I think our mission for this podcast is, as you know, pediatrics in general needs to change. As physicians, we lost our voices because of the health systems, because of technology and the insurance industry. There are a lot of great physicians like you guys and others that I've encountered over the years that have great ideas, and they manage to navigate the health minefield with a lot of success. We need to help elevate their voice. We need to get these people back into the center of the patient medical home. And more importantly, we have to get them at the center of the physician-patient relationship. I guess this podcast is designed to bring all this together and elevate the voice of successful physicians and pediatricians across the country and share their good ideas. There are lots and lots of private physicians out there that have been really successful. But, back to the academic stuff, it seems to be only the academics that, get the airtime.
How about you, Mick? Why do you think we should do this?
Yeah, Herb, I think it really goes back to how you named it, which I give you great credit for, the Pediatric Lounge, because I think in our days, there used to be a medical staff lounge. There used to be a place where physicians of all specialties could come together and discuss and interact and tell their stories. Hearing George stories about Romania, and certainly we all have our stories of why we went into pediatrics and what we do and how we do it. And I think we've kind of lost that communication. And so I'm hopeful this podcast will create dialogue around any and all topics related to being a physician and being a pediatrician, but really bring back maybe some of that camaraderie and that good, healthy discussion that we used to have over lunch or over breakfast, in that pediatric lounge back in the day.
When I talk to my colleagues, especially those in smaller primary care practices, they always feel this isolation. And there's a little bit of paranoia that the health systems and the payer systems have done that on purpose. We've been so isolated from each other as physicians and colleagues, and these conversations are not happening. And so we don't have a united voice, and we can't advocate for our patients anymore. So I'm thinking this is a great venue for trying to recreate that voice that we have lost. You have a very interesting background, and I one of the things that fascinates me is your constant need to innovate. And how did you go about from being a pediatric emergency room physician, seeing children crying and with injuries, into building a tech company?
Yeah, it's been an interesting career. As I told you my story, I really thought I'd be a pediatric oncologist when I was done with my training. But my first year of med school, my fourth year of med school, I did my first outpatient rotation in pediatric oncology. And the first patient I saw was a terminal Wilms patient. So I'm like, man, we can't do this. It's too close to home. So I went into pediatric emergency medicine and really just loved being a child advocate and continually trying to improve care. So I started in the pediatric emergency department, worked in emergency medical services for children, worked a lot in injury prevention. Shortly thereafter, saw a need as George recognized, MRI scans came along and kids couldn't lie still. So my first innovation there was to develop a pediatric sedation service where we help kids sedated for procedures. And really, it was pretty simple. It was all about getting the patient to the right place at the right time with the right provider with the right medication. So for me, it was solving a problem. It wasn't a workaround. It wasn't, hey, what size papoose board do we need to hold this child down to get it done? And that really spurred me into more of the business mindset of how do I start a practice? How do I contract with the hospital? How do I contract with payers? How do I hire physicians and those kind of things? And it was very empowering to recognize that to your point earlier, we have control. I mean, I think as physicians, we can continually innovate and take control of, and not just leave it to the insurers and the payers. So from there, long story short, I was recruited to Connecticut Children's, went back into academics, and after leaving Connecticut, came back to the emergency department and really got interested in the technology because I saw such a dramatic change. There was 8 years between doing ER shifts for me when I did pediatric sedation and pain medicine. And when I came back, I was just struck by how many kids were going to urgent cares and retail clinics and not seeing their pediatrician. When I left 8 years earlier, I was talking to pediatricians every night about patients they were referring in. And when I came back, the patients weren't seeing their pediatricians. I wasn't talking to pediatricians. And I saw the likes of Teladoc and MD Live coming. And I just didn't understand why we couldn't use technology to be a connector. So that's really what spurred it. The technology, I always tell folks I was the least tech savvy person ever to start a tech company. Because to me, it really wasn't about the technology. It was about how do we get kids to the right place at the right time with the right provider, and been a huge advocate for the medical home and trusted pediatric care and relationships. So it was a phenomenal ride to learn technology, but also most of my job was really trying to influence pediatricians to, adopt technology, embrace access for their patients, streamline care, improve efficiencies. And to me, that's, again, it goes back to George's point of whether we lost things as pediatricians, whether they were taken away, and what responsibility we have. So I guess I've always taken the sense that, we're at least 50% at fault for where we're at right now. And I think if physicians and pediatricians can take ownership, we can innovate, we can change, we can do different practice models, we can empower each other to, get back to discussing key topics, arguing, disagreeing, agreeing, but really, just kind of getting away from what I call kind of a learned helplessness, that everything is everybody else's fault. And we really have an opportunity through podcasts like this, dialogue, discussion, innovation, to kind of bring back healthcare to where we want it to be and why we went into it. I mean, I think we all went into pediatrics not for the money, not for the glory, not for the fame. We just wanted to get better care for kids. And so I think there's real opportunities there if we can continue to drive innovation, especially physician-led innovation.
I think that all of this learned helplessness, or all the stuff that we're talking about, that's kind of just like a thing that's happening out there. It's just like words. And who are making these words? Health systems, corporations, big hospitals. I think they want to push this message out that you as a solo practitioner, you can't do anything. But you know what? You can. The patients love you. The patients just love their pediatrician. So we got to get this message out that, you know what? Pediatrics and primary care, that's the way to go.
Yeah. And I think I'll add to that, George, because I think, there's a lot of, to your point, there's a lot of, hey, you're burnt out. Hey, you can't do this. Hey, you can't do that. But gosh, I tell you, when I walk into a patient room and interact with a patient and tell a stupid joke that they laugh at, there's just nothing better than that hands-on care and taking care of patients. And I think sometimes we get lost in the muckety muck. And I think folks have to recognize how great it is to take care of patients, to interact, to form those relationships, to all those things are kind of getting lost in the dialogue. That being a doc isn't about AI and technology and EMRs and those kind of things. The real joy and reward comes from, taking care of patients. And that's still there despite all the craziness around us.
Well, so I want to get back to some of that in a minute. But before that, I want to know what George has done both in the clinically integrated network in Long Island, and you have two urgent cares,
Correct.
but they dovetail very well with your medical home.
Correct.
So what's the difference?
The difference is I listened. All right. Some entity somewhere is saying to do things. Okay. So I'm on this big pediatric listserv where physicians across the country just talk about things. And then everybody's complaining about retail-based centers, or they're stealing our bread, urgent cares. They're taking out patients. You know what? Do something about it. Open up your office later. Stay on the weekend. Work on Sunday. Find some solution to the problem. All right. Otherwise, somebody else will. All right. So what we did is we hired more people. We expanded the hours. We were always open in the evenings and on the weekends. We just expanded it. Yes, I can't do it all, but you just get more doctors to work it. And if you build it, they will come. I assure you of that. But the problem that we're having, new doctors that we're trying to hire from these days, do you know what? they expect to not work on Saturday and Sunday. Now, I don't want physicians to work on Saturday, every Sunday of the month. But, you got to share it. If you have a lot of people, you just share the coverage and you provide good service. And the interesting thing is, it's their generation of mom that expects this kind of service that they don't want to provide.
So let me, because I haven't been to your office, I'll have to go up to New York for that.
Yeah.
But is your urgent cares, are they separate from your 3 medical practices, or are they in the same physical space?
I get that question asked a lot. Now, why is that question? Why should it be separate? It should be the same medical home. You should provide our tagline: primary care when you want it, urgent care when you need it. People should not call and say, I'll get you in 5 days. They should call, I'll get you in 5 minutes.
And what if a patient shows up and they're not your patient? They belong to my practice.
Right.
Will you still see them through the urgent care and then send me a report?
Well, that's the difference with the urgent care and the primary care. And this was a problem created by the insurance carrier. If you're the PCP on the card and you show up in my office under the regular primary care contract, we cannot see them because they expect you to see them.
Yes.
But so that's why you have to get separate contracts where it kind of deactivates that PCP and then you can see them.
Yes.
So that's the difference.
So currently, could you see one of my patients if I sent them for a sprained ankle and I wasn't able to see him at 10 in the morning?
If our urgent care has an arrangement with that particular insurance company,
yes,
we can. We have a good arrangement with a bunch of them. Some of them are still stuck in the old ways of doing things, and they ask the question, well, it should be a separate building, it should be a separate. I mean, why do you need to duplicate services, which is what we do in medicine all the time, duplication of services? The rent is already paid, the electricity is already paid, the computers are there, the staff is there, they'll love to work more.
So tell me about the clinically integrated network. This is one of the few rare practices without walls, which is a concept that's been around for a very long time. But very few pediatricians are actually doing it. How are you guys doing it in New York, and why is it not national?
Clinically integrated networks is, I believe, designed by somebody, but it's used a lot in hospitals because everything that you do ends up being the hospital level. So I'm the hospital, I make a CIN, I get all these doctors to connect, and I got a CIN. It's all sort of kind of smoke and mirrors sometimes. It's just a different version of an IPA. It's just organizing physicians. So what I did is I saw that in our medical community, and we call it the medical neighborhood, there was 2 competing hospital systems, right? One of them that was a big one took over this hospital that was 3 miles away and went to the children's hospital that we have and basically took the entire pediatric cardiology department and transplanted it into their system 2 miles away. Everybody, doctors, nurses, techs, echo people. And then I went to the director of the pediatric hospital and said, this is shots fired. They're coming after the heart, then is the brain, then is the lungs, then is the GI, then it's me. And this was before all this stuff happened. So we got to do something. We got to get docs together. So I got all these docs together when they were doing all the distrips, and people weren't really sophisticated yet. A couple of years ago, I got them in a room and I said, listen, I'm afraid, this is my fear. I think my group, RBK Pediatrics, is big enough to weather the storm. And when all this is over, my fear is that you guys are not going to weather the storm, and you guys will all, the 2-guy shows, the 3-guy operation, the 1-guy operation, you guys will all sell out to the systems. And then my group will be the last man standing that's private. And then what happens? So better to befriend everybody and work together and share resources and education and work plans and processes legally by creating a tax, a sole tax ID number for these things, and share best practices and create a medical neighborhood. And that's what it's about.
And one thing that fascinates me about what you have done, which very few physicians understand, are what we call KPIs in the industry, or dashboards.
Right.
And you told me the CIN has dashboards with KPIs that help physicians improve care.
Right.
How did you come about designing these?
Well, it's very interesting because anytime you do a project like this, it costs a lot of money. So now I have a vision to create a medical neighborhood, and then I need money to make it legal. So I got to ask you for some money. I got to ask that guy for some money. And you know, the statement is always the same. What's in it for me? If I give you money, what's in it for me? And I said, I don't know, to keep your independence in the future. I think that's very important. So let's get together. So then, you know, what keeps it legal and everything, besides, you know, the operating agreement and the tax ID number and all, is this clinical dashboard, because you're supposed to pull data, and you're supposed to do performance measures, and you're supposed to do good things, good medicine. You know, all these tech companies, I love them, no offense, Mick, but you know, they all charge a lot of money. I was quoted like $500,000 to get it all together, and then, you know, $200,000 a year just for maintenance on something that's a vision. It's a hard sell. So, you know, I went, and then also everybody has a different EHR. So what hospitals do when they make their systems is they force you to join their Epic or whatever system that they have. I mean, I lived through changing of EHRs, going from paper to an EHR, from an EHR to another one. It's very painful. It's very painful. Why would you want to make the doctor do that?
No. And Mick, and I, you know, we have many conversations throughout the years. And I keep coming back to something that you say often. And I also heard the CEO of a bridge say it. And you said it again in this podcast. There isn't anything more fun in life than the conversation that happens between a doctor and a patient. You cannot replicate that. And it seems to me that is what we have lost.
Yes.
The ability to sit and be human, have the conversation, tell a joke, pat the kid on the head, put your hand over the shoulder of a mom that's worried when there's nothing to worry about, and build relationships. And these relationships are not just between me and the child who's my patient, me and the mother and the dad who are my patients. You know, whether you like it or not, they're my patients, because if the mom gets sick, no one takes care of the kid. And me and the orthopedic surgeon, me and the dermatologist, me and the ER doctor, me and the urgent care doctor, those relationships in our ecosystem, but in society as a whole, are fracturing. And I think they're creating a lot of distress, emotional distress. And that's probably, is a very uneducated guess, one of the reasons of high degree of physician burnout, one of the reasons for high levels of anxiety and depression in the pediatric emergency room. And I think when I talk to the two of you, we want to be very focused on maintaining that conversation and building relationships. And that's what attracted me to help you guys create this podcast. What are your thoughts on that, Mick?
Well, I think at the end of the day, I mean, even if you look at the data, I mean, the patient-centered medical home is where you get more value, more bang for your buck. It costs patients less if they, you know, utilize a patient-centered medical home. And I think what we've really lost in all this, you know, to your point, is just the simplistic nature of healthcare. It's really, you know, 90% of it's a history. You know, it's all about conversation. It's all about interaction. It's all about, you know, forming that relationship, whether it's laying hands on, whether it's talking on a phone, whether it's doing a video visit. You know, to me, it's all the fragmentation that's gone on. And that's why I give George credit for the CIN. I mean, recognizing that the relationships among his fellow physicians and bringing them together is critically important, you know, for survival, as it is, you know, in the ER. it's remarkable. I mean, the nurses and the doctors in the ER during my shifts rarely converse. Most is, through Epic, and then they get the order, and then they fill the order, and then they, the only time they question is when the order looks wacky because Epic has done something to my order, or, it's put in wrong, or you put in a right, or Epic's changed it to a left. It's really quite remarkable. So we need to bring back more of this discussion around relationships, and to your point, really celebrate, the good is still there, right? Whatever interaction and fostering that relationship, whether it's a longstanding continual relationship George has or you have with your patients, or it's me in the ER where I get that chance to interact with someone for 15 minutes. It's really about that interaction. And you can tell from a patient perspective, when you do a good job and when you connect with them and when they're, happy with your advice. And I see them when they've been to the retail clinic, the urgent care, and then come to the ER all in the same evening because they haven't trusted exactly what the care they've gotten. So to me, that relationship is the only thing that's ever going to have any lasting impact. And despite all the craziness, it's still about relationships, and medicine will always be an art and it won't be a science. That's just the way I see it. And we don't celebrate that enough, about those interactions, those relationships, the care. As you know, pediatrics is 90% reassurance. There's 10% is what I do with a test or an exam. It's 90% listening and reassuring.
I blame it all on technology. Okay. Now, I am the number one fan of technology. My office is totally tech. All right. But it's not so much the technology. I blame the physician, because his relationship now became with the computer. Go to Epic. In the old days, you go to the hospital, you talk to a nurse, talk to you about the case. You'd write an order. You tell them, I wrote an order for this, that, and the other thing. Have a nice day. Now you go see the patient, and you, like Mick says, I still talk to the nurse. I say, look, I wrote an order to discharge this patient. I wrote an order to put ceftriaxone on. We still go to the hospital because you need a relationship with the hospital. The mothers like to see us in the newborn nursery. The families like it when their kid with asthma is in the hospital and their doctor comes to see them. I mean, there's something to that. The best words I've ever heard from a patient is when I did a college physical on a kid, and I see the mother with a tear in her eye, and she says, do you know, little Johnny, Dr. Rogu's the first doctor to put hands on you and check you out and examine you in the nursery 18 years ago.
Yeah, that's a big win.
It's no money. There's no financial gain, but you know what? That is a big win. That's priceless. And it happens over and over again.
So George, tell me about your guitars. You have a bunch of guitars behind you. What kind of music do you play?
What do you think? Classic rock.
Classic rock.
Now there's something to guitaring, okay? Physician burnout. Very, very important. I should be the number one burnout, but I'm not.
So it's the guitars that keep you from burning out?
Because I do other things. Every Tuesday, I go and I play with a band at this music school. There's always somebody to play with. And, I always bring it back to medicine. We've taken that. We made bands. We had a silly band called Doc and the Flu Shots, where we made medical fundraisers.
So are you going to play a guitar for us in one of the podcasts?
No. In a band.
How about you? What do you do for fun?
Oh, me?
Nick, yes.
I believe in work. Now work on top of work. No, I'm actually going fishing this weekend, play a little golf. But for me, that work-life balance is really more about how can I spend more time with my family and take care of myself. I mean, I think that's always the hard part. I think we're trained in medical school that an 80-hour work week is pretty normal. And as I went into emergency medicine thinking that would help control my schedule and I would have to have a work-life balance. But what I found is I could do administrative work during the day and then work all night in the ER. So it really comes down to each personal choice. And my burnout has probably been more self-inflicted than anything else. Just trying to do too much and trying to, be too passionate, innovative, and those kind of things. So I think it's I always laugh at folks and say there's a gas pedal and the brake. I'll hit the gas pedal and you hit the brake.
I would call that entrepreneurial, right?
So I have two more questions for you, Mick. One is, you're big into innovation. That seems to be a passion throughout your career. And you are now the chairman of the board of this Pediatric Institute for Innovation. And in some of the conversations we have about this, we talk about the importance of the human element connecting to digital technology. What, the lingo is digital illiteracy. And it seems that you're leading this institute into that gap to study it and solve it. Can you tell us more about that?
Yeah, I think, the Institute of Pediatric Innovation just kind of follows with, lots of different things that I've done over my career. But, I tell you that, back to, the question about technology, the inspiration for me in forming the tech company was going back in the ER and seeing a mom. And, I was on paper when I left. And when I came back, had electronic medical record, which then allowed me to see how many times a child had been seen. And I had a 2-year-old kiddo, no healthy kid, no medical problems, who had been in the ER 26 times. And
Wow.
I was like, man, I'm not cynical. I can't get grumpy. People are like, gosh, she's always here, yada, yada, yada. And I walked in and I said, hey, mom, how you doing? I see Johnny's been here a lot. Can I help you get connected with a pediatrician? And so you don't have to come to the ER all the time, in a helpful kind of way. But it's almost like she knew I was coming, and she looked at me and said, Doc, you just don't get it. I work Monday through Friday, 9 to 5. I work a minimum wage job. If I leave work, I don't get paid. If I leave work, I might get fired. And I'm assigned to a community health center where I work Monday through Friday, 9 to 5. So, that was really the only option for her. So to me, that drove me to anytime and kind of connecting and relationships, and technology really offers an opportunity for us to be able to connect just like this, to have this kind of conversation with, from 3 different cities. And for the underserved population, they don't have the same resources, same abilities, whether they don't have the smartphone, whether they don't have broadband, whether they don't have an ability to use the technology. Nobody's kind of shown them, and they're kind of left to taking the bus and waiting in line and, being, waiting for hours for a kiddo that they're worried about. So for me, the Institute for Pediatric Innovation is really focused on that digital divide, which is more than just, we've learned, is more than just handing somebody a smartphone or giving them broadband. There's a huge gap in folks' ability to utilize technology. So we're really trying to step in there where folks, whether you certainly hear a lot about seniors, but there's a lot in pediatrics, and especially among parents, that just don't have that literacy or that trust. One of the challenges, I think, for parents these days is access is hard. It's hard to access your pediatrician. It's hard to access the office. It's hard to use technology to schedule an appointment. I don't know if you've tried to call, part of my role at any time at one point is we were trying to call pediatric offices. Good luck.
Oh,
I mean, trying to get through. I mean, the other day I really wanted to talk to a pediatrician, and trying to get through their phone tree just to talk to a pediatrician about their patient that was in the emergency department was incredibly painful. I can only imagine, how these patients are just kind of left to come to the ER, do other things. So, back to the original thing. I mean, I think there is, we can't just throw technology at it. We can't just have it for the haves and not the have-nots. And there's a huge gap that's, social, economic, but I think educational as well, that we need to intervene. And that's where the Institute for Pediatric Innovation is trying to really embrace that divide and see if there's ways that we can close some of that gap, so that all kids have the same access to technology and the resources that they need.
Well, I see
I'd like to go
yes.
off on that statement where Mick said he saw the patient that went 25 times to the emergency room. That's one of the projects where we can take through our clinically integrated network, and we're going to be working on to see, we're pulling the 827 files from all practices with any EHR. So you don't have to go to one EHR. You can have PCC, you can have Office Practicum, you can have Epic, you can have eClinical Works. It pulls it into this dashboard, right? And the idea is to get the data from the insurance companies, which we are, and then pull out the person that's been going to the emergency room 25 times, and then find them and then say, hey, Mrs. Jones, why are you going to the emergency room so often? And then if the answer is, as Mick would say, said, well, do you know that, within our medical neighborhood, we have a pediatric urgent care. So you can go be seen at 10 o'clock and it's okay. So you don't have to go to emergency room for your little ear infection. It makes everybody happy. And then also back to the phone tree. Since my practice is so heavy with the tech, but I am so heavy with the relationship, we did a phone tree also. And then we started to have problems from the emergency room saying it's impossible to get through to you guys because we have a centralized call center that you call there, then they call us, and then the secretary gets me. We put another step directly into all these things. Now, the reason that happened is because there was no physician involvement when they developed it. All right. It's beneath them. All right. So my wife works in the pediatric ER and she calls a private line. She knows and she gets through. And then one time, I don't know, she did something, she couldn't get through the private line. So she went through, she said, this is crazy to get a hold of you people. We made a phone line just for the ER. How simple is that? It goes directly to where the doctors are. A simple work plan change and everybody's happy.
Yeah, I think that's so key, George. I mean, it's what I say, we're running so fast on the wheel. We're like a rat on a wheel that every once in a while you got to jump off the wheel and say, hey, can I do something differently here? And a lot of times it's not hard. Like, I mean,
no, it's always a simple resolution.
When I developed the sedation service, I was amazed because what we turned into was the care coordinators, because kids would have a CT one day, an LP the next day, something else. Nobody was connecting the dots. And so a child could get to the OR one day, get sedated for something this day, and the next thing we knew, we were like, well, wait a minute, this kid's got 3 tests. We can combine those. We can put those together. I mean, there wasn't any rocket science to any of this, right? It's all about process and right place, right time, right provider. And the physicians leading that, like you've done, is phenomenal. I mean, it's really not, like, hey, wait a minute, the ER can complain about you and you can complain about the ER. And you came together and found a solution that works. And that's, and it's a tin can and a string would work just as well, right? I mean, it's just amazing.
But there is a difference. There is a difference. I'm a private enterprise. I can go and make a change just like that. If you worked for a system, why would I want to? It's not my problem. There's a department that deals with this. And if it's really a big significant change, let the administration do it. And it's somebody else's problem. And they're usually not physicians. What do they care?
And it's not only that, it's how many meetings to set up that phone line.
Yeah.
You have to get the chief of operations, the chief of nursing, the chief of tech, and the operators into a room and have 5 conversations of 3 hours before, they decide to put out a request for proposals.
Correct.
Anyhow, we're getting short on time. So, George, I have a couple more questions for you.
Okay.
Who are you looking forward to interviewing in the podcast?
Who am I looking forward to?
One person.
I have a lot of people.
I know, but who's the one person and why?
I don't know. I think Dr. Connors.
Dr. Connors?
I know him well.
Yeah, we can always talk. We can talk all day long, right? There's so many great things.
And then,
do you know how I met Dr. Connors? I went to an office practicum conference. He had his booth over there for Anytime Pediatrics. I walked by and say, another vendor. I walked by. He says a couple of words to me. I stopped. He says a couple of more words. And then I realized that this guy is not a salesman. This guy's a physician, but his tag said Mick. And then we got to talking that he was a physician, so I paid attention. And the reason I love their company, truthfully, when you guys started Anytime, it was a little buggy, but now it's great because it was physician-led, and I supported the physician-led vendor. There was plenty of other vendors, but I went to the physician-led vendor because I think it's very important.
George, are you reading any interesting books right now?
I try not to waste time. So when I walk the dog or drive, I listen to books, audiobooks on Amazon. I'm trying to do all these financial things, anything that's an audiobook, I listen to while walking the dog, driving, because that's all dead time.
So what are you listening to on Amazon?
Right
books?
now, I just read actually a very interesting physician wrote this book. I like physician books. Dr. Una wrote a book, the Entree MD method, which She's a young physician, private practice, that knows a lot, but she knows how to bring doctors together. And I'm amazed at how she was able to get doctors together.
Wow.
Why can't we get that? The older generation.
We'll get
We
there.
have the experience.
I think we will get there.
We will get there. We will get there.
How about you, Mick? What are you reading nowadays?
The current book that my daughter gave me, it's called The Obstacle is the Way. So it aligns well with what we're talking about, that it's really and more a book about leadership and empowerment, that, you know, you gotta go through the obstacle. You can't go around it. And I see that in healthcare all the time. We're addicted to workarounds. We're addicted. Hey, if we just slide this way or slide that way or go around. So it's really a book that's kind of inspirational about taking risk and approaching the obstacle and kind of coming at it hard. And then I'd love my favorite thing to listen to or to read is Malcolm Gladwell. I mean, he just has a different perspective on everything. And, you know, if you know me, I'd love to be a contrarian, because I think it's really incredibly important to play devil's advocate or be a contrarian and say, hey, wait a minute, you know, like you guys are saying, this isn't the way we have to do things. We can do things differently. We can be empowered to do things, especially like George has done, or Dr. Una, or whoever is a you know, someone that fosters collaboration, brings people together. I mean, together you can do a lot. It's hard to do things individually, but together, I think physicians can really impact, you know, the future of healthcare. And I'm excited for this podcast, just to hear those other perspectives. And hopefully there's a lot of folks that disagree with what we say and are able to express that and have a different look. Because as a locums physician in the pediatric ER, nothing's been more profound than how different every pediatrician is, every pediatric ER, every practice. I mean, we all treat, you know, I joke with everybody and say, from asthma to enemas, every ER does it differently. I mean, it's really remarkable. So it's kind of crazy time. So I think.
And who do you think is a thought leader in change innovation that you want to host in the podcast?
Oh gosh, I mean, if I could really get a hold of that, it would be interesting. My favorite book is a book called Switch. It's by Dan Heath, and it's really about how to promote change and foster change. And he talks about the elephant, the rider, and the path. And it's I would love to pick his brain on those kind of things, because one of the things that's most profound, if folks read that book, is, you know, the real way to promote change is to promote best practice. So we need to find folks that are doing things successfully, like George. I can imagine that George's dashboard that he's developed could be replicated across the country. And you know, and I'm sure there's a lot of people spending a lot of money trying to do what he's already done. And especially in pediatrics, if we can come together and we can promote that best practice and replicate it. So there's oodles. One great thing about being on the vendor side, there's a lot of challenges, but one of the great things is you meet people like George and yourself that are out there changing and doing things. Dr. Russell Libby and Dr. Susan Sirota. So many people that have great practices that are developing and innovating that people don't know about. You know, and on the vendor side, there's so many great vendors, and but nobody knows about them, and we're all trying to reach the same audience. So hopefully we can bring that best practice together and replicate it.
I think the physician that I most admire, that I'm going to try to reach out to, is Dr. Sue Presley. I think she is the number one person, because she lived private practice, she lived technology, she lived everything, physician engagement, physician leadership. I think she brings everybody together, and she's great, especially from the EHR point of view. She taught me the best statement. I mean, she was instrumental to me when our EHR went out of business, and I texted her or emailed her. She says, call me up. So I call her up on a Saturday night, and she told me about another EHR product. We spoke for an hour, and she told me it'll be okay. We'll get you an EHR, and everything will be fine at the end of the day. And you know, as time passed on and I got to know her better, the 80-20 rule. Physicians tend to want to do everything perfectly before they launch. You know what? It'll never be perfect. Like this podcast we launched, we're not perfect yet. The 80-20 rule, 80% of the time, it'll be good enough. You deal with the 20% of the time when it's not, and you fix that and you build on that. So I no longer try to make perfect. I try to get it off the ground and get it moving. And I learned through technology, you know, these tech people, they sell a product before it's even built. You know, I learned that with, I was on the advisory board of this vaccine company, this vaccine ordering, inventory, you know, Candid it's called. They had a cool thing. We got together for the COVID vaccine clinics and we made a coalition to redistribute vaccines to the small practices within the CIN. And then as he's showing me the platform, we get it live in my office with the making of the appointments online and scanning and the vaccine and ordering and uploading to NICES. I realized that they don't have a product yet. They're building it. And I spoke to the guy, I said, buddy, I've been accused of flying the plane and building it at the same time, but at least I got some directions. You guys are figuring it out as you go.
Yeah, and technology.
That's how tech works. So I gave them some pointers and some stuff. Yeah. And now they have a really, really good product, but they're a small shop. They have to get into, you know, the big industry, but it's hard to break into the industry, even if you have a good product. And I've seen lots of good products just squashed by a big vendor. They just wanted to get the competition out, and they leave the big clunky bloated thing there for doctors to deal with. So Candid was really, really good.
Yeah. So I'm reading something, a book which I really like. Since you both know I'm very hyper.
Yes.
But it's called the 12-week year, and it's about executing projects in 12 weeks. If you can't get change accomplished in 20 weeks, it's probably not going to happen. Waiting till 2 years from now to be completed, you'll lose interest in the project and it'll be gone.
Right.
And other than Russ Libby on innovation, as you might know, he also hosted a radio show here. So I want him to give us pointers on how to make the podcast better.
Yeah, we'll get lots of people. For some reason I know everybody.
Yes, but I'm looking forward for Mick to connect us to the CEO and physician who started a bridge, because I feel he's really putting the conversation in the middle of technology, and he echoes this thought that we've heard multiple times now. It's we need the human touch. Technology aids and helps in the human touch. But if you decide technology without the human touch, you don't teach the child how to use that smartphone to connect with anytime, or a mental health app, or schedule an appointment. Or if you look at some of my colleagues' websites, they're not engaging, they're not inviting, they're not doing anything. So it's not just the child and the parent, it's the pediatricians. And so I think we're going to be able to have these conversations and put the conversation right at the center of the table where it needs to be, build relationships, and through the Institute for Pediatric Innovation, disseminate these best practices so that others can replicate it and so that we can all benefit. And I do want to see George's CIN go national. I think that would be a game changer.
It's all about relationships.
So that's one of my goals.
Yeah. And, interesting thing, last thought. The one thing that I realized in the office with the doctors is the relationships. Everybody had their consultation room, their little offices. So all the doctors are spread out all over the office. We built out our new office in Comac. And I said, we're making one central location where all the doctors sit. I'm sitting with the new doctor. I'm mentoring the new doctor by accident, and I'm listening to what they're doing. We're talking. I know about everybody's kid, who won what baseball match, little league game, who's going to a concert. You know, sometimes I know too much, but I think that fosters the friendship between the physicians in the office. And it's no longer us against them, or the partners against the employees, or the guys against the girls. We're all in it together. I think it's important.
I think to your point, George, it drives better care, right? You can interact on patients,
Yeah.
bounce things off each other.
Yeah.
I'm talking to a friend of mine who's a psychologist. He said, it's interesting. Years ago, they used to meet at lunchtime. There'd be 20 of them. They'd talk about all the inpatients they were caring for. They'd interact, they'd talk. And then the administration realized how much money, that those 20 folks could be seeing patients during that time. So they did away with it, and, all in the name of productivity. But in the end, likely those patients aren't getting the same level of care. It's the ripple effect that impacts so many of those things. So I bet your patients are getting a lot better care because now they get, 5 or 6 doctors' brains on it if there's a question or a conundrum or those kind of things. So
Yeah, I also listen to them sometimes when we do the telemedicine from there. Yeah, I hear one of the younger doctors talking and asking, and they're stumbling and they're having some difficulties. And I'm listening, and I whisper in their ear without the patient seeing me, ask them this question or do this, bring them in. This is more serious. There's somebody helping.
Yeah.
I think it's very important. Friendships between physicians is very important. And I think that's what is great about my practice partnership. You know what? We're partners, but we're friends.
Yep.
We're friends.
So Herb, thanks for launching this podcast, and hopefully it will continue to foster friendships and dialogue and discussions, and get us all a little out of our isolated silos. So this is great. Thanks, Herb.
Well, it's been great seeing you again.
All right.
And we look forward to seeing you next week.
All right. Thanks
And
a lot.
that's a wrap.
That's
All
all.
right. Thanks, guys.
Rock on.
All right.